Hi, everybody. We're back for part 2 of dementia. I promise this lecture is follows the book completely. And you'll notice even on the first slide, there's a lot of highlighting to do. So get your highlighter, get your book ready. We're going to be starting on page 508 in the book. And we're going to talk today about the 9 most common behaviors you will see in a person with Alzheimer's disease and a few little things on communicating with someone with dementia. So again, page 508, we're going to start with sundowning is the number 1. Oop, and I forgot the first bullet point that's highlighted, so let me stop you right there. Always, always, always report behavioral changes to the nurse. Behavioral changes can signal that they have an illness, an injury, or some of the meds that we're giving them might be affecting their behavior. So please let the nurse know as soon as you recognize something that's different. You are the front line, you are the ones with them more often, and you do recognize symptoms way faster than anybody else. So now we'll start with behavior number 1 is called sundowning. It literally is what it means. When the sun goes down, our friends, our dementia residents, will get a little bit more confused and restless, and that confusion will last all night long until the morning when daybreak and the sun comes up back again. I will tell you from personal experience, winter's crappy. Summer's much nicer because you have a lot more hours of light in the summer than you do in the winter. So people in the winter tend to have a lot longer period of confusion than they do in the summer. It's usually related to being tired or to being hungry. So in your book on page 508 in the right-hand column under sundowning, would you please highlight the definition and the 2 sentences beyond that that said, as daylight ends and darkness starts, confusion and restlessness increase, so do anxiety, agitation, and other symptoms. So that will be on the test tomorrow for you to remember. The second most common behavioral change that you will see are hallucinations and delusions. Now, hallucinations are something you see, hear, smell, or feel of something that is not really actually there. Most common hallucinations are animals, insects, or people. Some of our residents do have poor hearing and poor vision, so helping them wear their glasses will help them to see or to hear and might help a little bit in hindering them from seeing things that actually aren't there. So for that in your book, I need you to highlight, please, the definition of what hallucination is. And we're going to turn the page in a second and we're going to highlight what a delusion is. But a hallucination is something you hear, you see, you hear, you feel, or you smell. Delusion is a false belief, but to that person, that false belief is truly real. Some of the most common delusions, and honestly it does kind of come with a realism, is they feel like they were put in jail. If you think about it, all the doors are locked. You can't go outside when you want to. You have to eat 3 meals a day when they tell you to eat it. It possibly could look like a jail to somebody. One of the second most common ones is they feel like they're being killed. We do put a lot of meds in them, and so they kind of worry about what we're feeding them. Being poisoned by food and medicine is a common one. And then that they feel like they're being attacked. So again, in your book, please highlight delusions are a false belief, and know that some of the most common kinds are jail, being killed, poisoned by food and medicine, or being attacked. Number 3 of the most common behaviors seen is called catastrophic reaction. A catastrophic reaction is an extreme response to a normal event or thing. So sometimes, and you might know someone like this, when you touch somebody, they just like jump out of their chair and get all like their heart starts beating fast and they get all anxious and upset with you. That is a catastrophic reaction. For people with dementia, they're usually triggered by too much stimuli. So the phone's ringing, the TV's on, people are talking and laughing, people are walking around, and there's so many things going on that their brain can't handle all that stimulus, and they react to all that noise. One of the most common things that have catastrophic reactions is ringing phones. They hear a ringing noise. They're not sure what it is. They're not sure what to do about it. They're not sure if they're safe or not. So they react violently to a ringing phone. Most nursing homes do not have ringing phones. They have phones that vibrate. They're like cell phones, so they put them in your pocket, they vibrate. Or if they do have a desktop phone, then it's behind a door so that it's not ringing and scaring the residents when it rings. And again, if you did do clinical, you will notice that the call lights have a flashing light, but you don't hear any beeping noise because that noise will confuse them and could cause them to have a reaction that would not be one that you want to actually see in anyone. So in your book, again on page 508, the very last paragraph on the right-hand side says catastrophic reactions. Please highlight their extreme responses to normal events and things. And the reason for these reactions is commonly because of it's too much stimuli. And then what things can stimulate them, the phone and the call lights. Number 4 is wandering in our most common behaviors. Wandering is something you will find very often in nursing homes. It is something that most of the residents do. Residents are often disorientated to place and time, and when they wander off, they get lost. Sometimes it's just a matter of they go right down the hall instead of left where their room is, and they get lost and confused as to where they are. Due to their poor judgment, though, sometimes they can get themselves into pretty life-threatening situations. So if someone manages to get out of the locked unit, manages to get out the front door, then they walk outside. There's a street right there. They'll just keep walking. They don't realize that they need to stop and look both ways. If they're wandering around and get lost, they might not have any idea how to get back, and they could actually end up lost for quite long periods of time. Things that you should do for someone that's wandering. Allow them to wander in safe places. So usually hallways in the facility, the locked doors will keep them so that they can keep walking and walking and walking. Now, in some of the better facilities, you will find that they will put things in the hallway, pictures, a seat, so they can sit down with a box on it, or some kind of puzzle, or some kind of thing to stimulate them. They might have a music room where they can sit and listen to music. They put different areas in so that they can safely wander around the unit. They also usually have an outdoor garden, but generally they need to be monitored while they're outside. The residents should be wearing their ID bracelet at all times so that if they do again wander off and get out of the locked unit, we can look at their bracelet and know where they belong and bring them back. The door alarms need to be functioning. So you have to spend some time telling family members they can't hold the door open for a friend, or they're waiting for their wife to get around the corner. An open door is a dangerous thing to someone with dementia. So make sure that the door gets closed, and if they're waiting for someone else, they're just going to have to come and reopen it when they knock. Don't let the the doors stay propped open. And last but not least, all staff should know who the wanderers are so we can keep eyes out for them. I like to call it the most wanted posters. They're taped up to the desk in the nurse's station, and you can see all the people who have a tendency to wander, so that if you happen to see that person and they're not where they're supposed to be, you know to return them to where they're supposed to be. Elopement is the word for when they actually leave the agency, when they get out of doors without us knowing it. One of the things that the Alzheimer's Association has come up with, and they've worked with Medical Alert, is a system called Safe Return. So it's kind of like Amber Alert for people with dementia. The police, they get a bracelet or a necklace that they wear, and the police have pictures of them, a biography of them, and information about them, so that if we would call them and say that someone did get loose, they can immediately have the information they need to go looking for that person. My friend Park, her mother is from Korea. She emigrated here just a few years ago, and her English is non-existent, to be blunt. She lives in Evanston, and she was waiting for her bus to take her to daycare. She was confused. She thought it was Monday, but it was actually Sunday. So the bus never showed up because it wasn't. They don't have the daycare center open during the weekends. And so her Park's mom decided she was going to walk to the daycare center since the bus wasn't coming. Mrs. Park walked from Evanston, and hopefully, if you know, that's north of the Chicago city limits. She walked all the way to the oh my goodness, the Shed Aquarium. I don't know how far that is in miles, but that woman walked and walked. They finally found her that evening laying on a bench by the Shed Aquarium. The next day, Park was on the phone calling the Alzheimer's Association and arranging for one of those bracelets for her mom, the Safe Return bracelets for her mom, because she was terrified her mom might do that again. At least that one had a good outcome, but sometimes they don't. So if someone's wandering, allow them to wander in a safe place. Make sure that the doors stay locked, and so that they can't hopefully get out. And the residents should be wearing their bracelets, ID bracelets. If you go to page 509 in your book, in the blue box where it says wandering and getting lost, in the red italicized words, it says leaving the agency without knowledge is called elopement. That is a test question. You need to know what elopement is. And then in the paragraph just below that, that starts all staff, the second sentence says wandering is allowed in safe areas. I need you to highlight that. And then the very last paragraph on the left-hand side of page 509, the second two sentences. The person receives an ID card. Oh, that's for the Medical Alert. Sorry, that is not what I was looking for. All right. But the highlights are the things you need to do and the word elopement for wandering. Number 5, halfway there, is agitation and aggression. Agitation is the person who's restless, worried, and can't seem to settle down. They keep pacing, kind of like the animals in the zoo. They just keep going back and forth and back and forth and back and forth. If that agitation isn't dealt with, it can lead to aggression, where they begin yelling, screaming, swearing, hitting, pinching, or trying to hurt others. Some of the most common causes of this behavior are they're in pain, they're hungry or they're thirsty and they don't know where to go, so they figure if they keep walking, they'll figure it out. They need to use the bathroom. Sometimes giving care upsets them or frightens them and they become agitated. The last two are two things that I would love to highlight. It's not a test question, but it's really, really true. and residents will actually comment if they have the ability to, they will actually comment about this. If you're trying to rush them, if you're tapping your foot, if you're looking out the door, if you seem like you need to hurry up, if you seem like you're in a rush, you're trying to hand them things too fast, you're trying to get them to do things quickly, they will get agitated. And if that agitation and you don't fix your behavior, will turn into them yelling, screaming, and hitting, and outcomes you do not want to happen. The next one is giving confusing cues. If there's more of you in the room doing care and you're telling them to lift their left arm or their right arm, and the other person is trying to put their shoe on and tell them to lift their legs so they can put their shoe on, or you're trying to do multiple things at once, it's extremely confusing to them. They don't know what to listen to and where. They get very agitated when there's too much information coming into them. So appoint one of you to be the person to give directions and do things in singularly, and don't both of you be talking and trying to talk at the same time. You will avoid them getting agitated and aggressive if you can keep those two things in mind. So don't rush, and don't give multiple instructions all at one time. It really, really will confuse them. Number 6 is paranoia. Paranoia is where the person has false beliefs or suspicions about another person or situation. They believe that that other people are being mean to them, that they're lying about them, or they're out to get them. They're very suspicious and fearful, sometimes jealous. They believe things when two people are talking and laughing and they're walking past, they think that they're talking about them. Repetitive behaviors, number 7. Repetitive behaviors are when they do the same thing over and over and over and over again. It could be emotion. It could be like a hand movement, an eye movement, an arm or leg movement. This using the same word over and over and over and over again, or asking the same questions, just repeatedly asking the same questions. I'm going to give you a quick little story because I know our time is brief, but we had a resident, his name was Stuart, and 24 hours a day, Stuart said the same thing. What is my name? What is my name? What is my name? What is my name? You would say your name is Stuart, and before you could even say Stuart, he was asking again. It annoyed a lot of the staff members, and they would yell at him and tell him to stop doing it. The problem is you have to realize that part of Stuart's brain that recognizes that he's asking a question and that it was answered is gone. He didn't have any recollection of asking a question, and he didn't have any recollection that you answered the question. Take a deep breath. Realize it's a disease. It's not Stuart, who's just annoying as heck. It is something that happens to some of them, and it's something that if you have to answer it 100 times, smile and just keep going. Repetitive behaviors is a common thing that you'll see with dementia patients. Another one that's super common is rummaging. And rummaging is where they just start searching things. They move things around in their room. They turn things over, look at it all different directions, and they look like they're looking through they like to look through drawers and closets and things like that. So the behavior itself has no meaning. It's just something they feel like they need to do. When you ask them, why are you doing it? They have no idea what they want or what they're looking for, but they just have this habit of liking to rummage through things. So sometimes what we had in our facility is we put wooden boxes all over the place, on end tables, on tables, by chairs in the hallway. And each box had something in it. We had a box with Beanie Babies in it. We had a box with pieces of cloth in it, different kinds of cloth, flannel, fuzzy, wool, something scratchy, something cotton, so that they could just sit and feel and rummage through the colors and the sizes and the shapes of the box. We had one that had squishy balls in it. They love the squishy balls and just to spend hours squeezing on these balls. But you want them to rummage in safe places. You don't want them to go in other people's rooms and rummage. One of the things we really try to emphasize to the family is these rummaging behaviors are part of the disease. So if there's something that's really valuable to them, that's very important to the family, don't give it to us to have, because things do get misplaced quite often. So if they have a picture of their husband or their wife, it's a beautiful, special picture, and the family wants it as a keepsake forever, we take a Xerox copy of that picture and we put it in a cheap little frame. So if it gets lost, it's no big deal. We get another one from the family. We Xerox it, and we have another one for them. Always label their glasses, their teeth, and their hearing aids so they don't get misplaced. Uh, they residents have a really good habit of taking off their glasses and leaving them on a table, and somebody else puts them on. And then you're like, well, whose glasses are those? And sometimes it's really hard to distinguish one pair of glasses from one person to another. Teeth. They do in the newer dentures engrave names in their teeth so that we can, their dentures, so that we can know who they belong to. We had a resident, it was really kind of funny, but every night she would steal between 5 and 6 different pairs of residents' dentures. They'd be in her room in the morning, and we would just go in there and pick them up. And fortunately, they had names on them, and we would go bring them back to the resident who they belonged to before people realized that they were missing. Hearing aids, they like to take them out, but we had a solution for that too. We put the hearing aids, tied a string to the hearing aid, and then alligator clipped it to their shirt so that when they took them out, they were still hanging on their shirt and they wouldn't get lost, because, as you know, hearing aids cost an absolute fortune. So let's go through our book on page 510. I did forget to tell you to highlight repetitive behaviors. That is, I need you to highlight the definition for repetitive behaviors, which is doing over and over. And then the repeated motions are the same motion, words or questions over and over. And the person may say the same word or ask the same question over and over. So that first or the paragraph of repetitive behavior is a good one to highlight. Then under rummaging, I want you to highlight the first paragraph under rummaging, the definition of rummaging and the specific places where they like to rummage through. Okay. Oops, sorry, went the wrong way. Okay, the ninth, the last one that we're going to go through of our common behaviors is intimacy and sexuality. Intimacy is the special bond between two people who love and respect each other. Sexuality is the way that those partners physically express their feelings for each other. Now, we allow them to show affection. The husband and wife can hold hands, they can kiss, they can touch. Dancing together is a great way for the two of them to be able to connect. But sexual behaviors can be labeled abnormal because of where and how they choose to display their affections. So if it's in an inappropriate place, allow for them for privacy. Suggest they go to their room. When the husband or wife comes, have them go to their room, or have them go to a little alcove or a space that's not being used so that they can have time together. And it's not uncomfortable for everybody. Also realize that some of the touching that people do is not necessarily of a sexual nature. If they're touching their perineum or itching or scratching at their buttocks, there's possibility that there's something going on there. So when you take them to the restroom, check for infection. When you touch it, ask them, does this hurt? Is there a reddened area, areas of discomfort that you can detect? Let the nurse know, and we can try to address whatever that issue is. for them. In the book, under sexuality, underneath the purple bullet points, the first sentence after the bullet points says, sexual behaviors are labeled abnormal because of how and when they occur. And then skip down 2 paragraphs, and it starts, the nurse encourages the partners to show affection. Their normal practices are encouraged, and examples include hand-holding, hugging, kissing, touching, and dancing. And allow for privacy. Is another one, which at the moment I can't seem to find. Okay. All right, backing back to kind of going full circle from the beginning of yesterday's class, we talked about communication. With a confused patient, we're going to address it now with communications for changes in a person with dementia. As the disease progresses, their communication skills do decline. They will start having trouble expressing their thoughts and their emotions verbally. At first, they'll start with having problems finding the right words, which will eventually progress into their start speaking in much shorter sentences. Yes, no questions are always more ideal than open-ended questions, just like you guys would rather do matching than an open the fill in the blanks. Eventually, these sentences get shorter to where they become just single word answers. Once they lose their ability to do single words, their speech will turn into syllables, moans, groans, screaming. Screaming is a form of communication to someone who's very confused and can't speak anymore. So again, as I said before, people who cannot speak can still communicate with you. You can tell the difference between a cry for hunger, a cry for pain, and a cry for happiness. You will, as you deal with someone day to day, you will start figuring those things out, and it really does help. So in your book on page 511, on the right-hand side of the page under screaming, the second paragraph says screaming to communicate is common in persons who are confused and have poor communication skills. We're going to turn to us as communicators with someone with dementia. The 5, these are my top 5, Betty Jo top 5. They're in the book, in the box 35-8. There's a lot of bullet points there. I chose my favorites from the list, and so they go as this. Number 1, speak in a calm and gentle voice. If you're anxious, if you're upset, if you're angry, they have very good emotion detectors and they will pick up on it. So calm and gentle voice. Now, that doesn't mean you don't have to talk loudly, because some of the people are hard of hearing, so you will have to speak up. But don't yell, because it implies that you're angry. Number 2, speak slowly. Use simple words. Don't use those big fancy medical words we just taught you. You have to go back down to words that the common average person understands. Use short sentences. Do not make super long explanations about things. If you just want to know if they're hungry, are you hungry is fine. You do not have to go into long sentences at all. Something, again, Trivia 101 that's I find very fascinating is they lose their ability to understand every fourth word you say. So I'm going to give you an example. And I'm going to pick Mrs. Bartels to use. And that is, Lori, are you hungry? So Lori is word 1. R is number 2. You, number 3. The fourth word is hungry. So all the person with dementia heard was, Lori, are you? So they're not answering you, and you're thinking they're just being stubborn or they're being uncooperative, when in fact they're waiting for you to tell them, am I? What are you asking me? Whereas if you would have said hungry or you hungry, they would have understood. They would have been able to process that so much better. So again, I'm going to give you a little homework assignment. Not right now, but I want you to think about this. Sometime today, you told somebody to do something. I'm sure you did. Mom, dad, brother, sister, you told somebody to do something. I want you to write what you told them down word for word. Then I want you to take whatever you said and I want you to count out and cross out every fourth word of whatever you said to that person. Reread the sentence and see if it makes any sense. When you talk to someone with dementia, try and keep it simple and short. Every fourth word is dropped when you speak to them. Number 3, let the person speak. Don't interrupt them or rush them. It's going to take them a long time because those synapses, those connections between cell to cell of what you're going to say are going to take, it's longer for them to think of what they want to say and to get that information to their mouth. So let them take their time and don't interrupt them and don't rush them. It's kind of like me when I speak Spanish. I have never gotten to the point where I can speak it without thinking about it. So I have to think in my head in English, then I have to translate it to myself, and then I can speak it. It takes me a very long time to respond to a Spanish sentence, just because I have all those extra steps of processing it. Number 4, give them time to respond. Again, it's going to take a while once they hear what you're saying. So you say hungry, it's going to take a while for that brain to process hungry. Yes, no, I have to think about it. So allow them the time that they need to formulate that answer. The last one, do not criticize, do not correct. So if they say something wrong, if they say your name wrong, if they say their family member's name wrong, if they say the wrong word, do not correct them. If you do, it's going to make them angry. They will not remember why they're angry, but that anger will stay with them throughout the entire day. But they'll just know that they're upset about something. The same thing with interrupting. Don't interrupt them to give them to help them talk faster or to help simplify the information. Argue. Do not argue with someone who doesn't have all their brain cells. You're never going to win. And what you're doing is making them upset and angry. And again, it's going to stay with them all day. They're not going to remember that it was an argument over somebody correcting me or not allowing me to be correct. They will just be angry, period. Don't try to reason with someone that doesn't have all their brain cells. You can't rationally argue with someone who doesn't have the capacity to be able to respond to what you're saying. So reasoning with somebody, you can't do that because it doesn't work. It again will just antagonize them, and that feeling is going to stay with them, and you're going to have a really hard time with that resident for the rest of the day. These are a couple little potpourris, I would like to call them. Oops, I'm sorry. Let me back up. Betty Jo, getting too anxious here. In box 35-8, I need you to highlight the following bullet points. Number 11, speak in a calm, gentle voice. Number 15, speak slowly. Use simple words and short sentences. In the right-hand column, number 5, let the person speak and not interrupt. Number 6, give the person time to respond. And number 9, don't criticize, correct, interrupt, argue, or try to reason with that person. Okay, on the home stretch here, I have my potpourri slide here. All right, observe the person for changes in behavior, because changes in behavior signal, possibly may signal that there's something going on. Dementia residents have the same rights as anybody else. Just because they don't have a very good memory doesn't mean they don't have rights. We don't take them away. So dementia residents have the rights to choose, but limit their choices, because if you open up the closet and say, what do you want to wear? All those clothes in that closet will just confuse them. So go in the closet, pick 2 appropriate shirts for the season, and ask them, do you want this one or that one? Now, if they're not having, if the dementia is not that advanced, you can say, do you like the red one or the purple one? If it's more advanced, they do have problems with colors eventually. So you might just have to show them the shirts themselves and let them just point to whichever one they are. If you want them to choose between coffee or juice, show them a cup of juice and a cup of coffee. Coffee or juice, let them point to the one they want. They have the right to choose what they want. The last little bullet point under potpourri is not on the quiz. It's not highlighted, but just so that, and again, I think this might be something on the state test. Dementia units are locked units. The locks on the doors are considered restraints. So every 90 days, the health team has to get together to review the person's condition and determine whether they still need to be in a locked unit. So someone who becomes severely demented and is bedridden and cannot no longer walks and wanders is not at risk of leaving. There's really no reason to keep them in a locked unit, and they can be transferred to a regular unit. But they have a 90-day, every 90 days, we have to talk about each one of the residents and whether or not they need to remain in a locked unit. The next slide here is on family. There's nothing on the test about family, so I left it in there, but you're not responsible for knowing that now. But again, I don't know if there would be a test question coming on the state test. My last slide is on validation therapy. Validation therapy is found in your book on page, oops, sorry, it flipped back on me, page 517. This is one of the therapy modes that dementia units use. It was developed by a woman named Naomi Fell, which you do not need to know. But Naomi's has her perspective is that the following, that all behavior has meaning. It's our job to figure out that what this behavior means for that person. So if they do a certain thing, it might mean that they're doing a certain thing. So all behavior has meaning. The second bullet point says, do not attempt to bring the person back to reality. That, my friends, is something we used to do many years ago. And I always thought it was cruel and unusual punishment. My resident who didn't know, who had dementia, was calling out for their mother. And I'd have to say, your mother's been dead for 30 years. And when you say it, it's just like it is. It's like it happened that moment, and they start grieving and crying and upset for hours and days at sometimes. So Naomi says, don't bring them back to reality. If they think that they're 16 years old and they're going on a date tonight, there's no harm. Let them be 16 years old and go on a date. Don't bring them back to reality. Don't remind them they're 80 and their husband died 3 years ago. One of Naomi's principles is that the mind returns to the past to work on unresolved issues and emotions. So that is why they do what they do, because they're going back in time to something that happened and they're trying to resolve that issue. So maybe their father and they didn't have a very good relationship. So they're going back in the past to try to recreate that time so that they can resolve those issues and emotions. And Naomi believes that all caregivers should listen and provide empathy, and understand what's going on with the residents. So in your book on page 517, under validation therapy, there's 4 bullet points. I would like you, or 5 bullet points. There's one on the other page on the right-hand column. So I'd like you to highlight those 5 bullet points, please. All behavior has meaning. A person may have unresolved issues. A person's mind may return to the past. Caregivers need to listen and provide empathy, and attempts are not made to correct thoughts or bring a person back into reality. This very last slide is suggestions for you if you want to know more about dementia. These are some of my favorite things, and if we were in school, I would have played them for you. The first one is a video of Naomi Feil using her validation therapy on a woman named Gladys Wilson. I will give you a warning. It's a 2-handkerchiefer. It's got a very great ending on it, and it's only maybe about 5-6 minutes long. Number 3 on the list, Inside Alive, the clip with Henry. I love that clip. I use it constantly. It's about using music as a therapy to help bring back memories to people. And literally, Henry becomes alive when they put headphones on his ears. It's 5 minutes long. It's beautiful. It's wonderful. I really would encourage you to try that one. One of the other people who has a lot of great ideas about how to care for people with dementia is Jolene Brackey. She has a YouTube video with her principles of creating moments of joy. That's excellent. And then lastly is Teepa Snow. She has a gazillion different videos out there. You could spend hours and days watching her videos, but she has a lot of practical advice, like how to feed somebody who doesn't want to eat, how to dress somebody who doesn't want to be dressed, how to give someone a bath that doesn't like to be take a bath. I will warn you though, it's kind of funny, but Teepa's from the South and she does swear quite often. So if you have little kids around, you might want to put your headphones on. Guys, that's the end of Dementia. I thank you for listening. I wish you luck tomorrow on the quiz. Have a great day. We'll talk to you soon. Bye-bye.